Welcome to today's event, Clinical Borders, Bodies and Healthcare in the Central Mediterranean Route. I'm Seth Holmes. I'm Chancellor's Professor of Society and Environment in the Environmental Science Policy and Management Department and part of the program in medical anthropology and co-chair of the Berkeley Center for Social Medicine, which is sponsoring today's event. I want to thank our co-sponsors, the Institute of European Studies, the Berkeley Interdisciplinary Migration Initiative, the Department of Anthropology, and the Center for Ethnographic Research. Before I go any further, I want to acknowledge that UC Berkeley sits on the territory of the Huchun, the ancestral and unceded land of the Chochenyo Ohlone. This land was and continues to be of great importance to the Ohlone people. We recognize that every member of the Berkeley community has benefited and continues to benefit from the use and occupation of this land since the institution's founding in 1868. Consistent with the university values of community and diversity, we have a responsibility to acknowledge and make visible the university's relationship with Native peoples. By offering this land acknowledgement, we affirm Indigenous sovereignty and our commitment to hold the university more accountable to the needs of American Indian and Indigenous peoples. The format of today's event is that after I introduce Lorenzo Alunni, he will talk for about 30 minutes. Then we'll have a discussion. If you have a question, please use the question and answer Q&A feature. And Charles Briggs, my co-chair in the Berkeley Center for Social Medicine, will ask those questions on your behalf. I also want to acknowledge that in the context of violence and displacement on massive scales in the world right now, it's both difficult and important to think about borders and bodies. And now it's my pleasure to introduce Dr. Lorenzo Alunni, researcher at the University of Milan-Bicocca, where he teaches medical anthropology. In 2022 to 2023, he was a member of the Institute for Advanced Study at Princeton at the School of Social Science. After working on Roma camps in Italy and their medical management, he's now inquiring into the corporeal experience of the contemporary Mediterranean border and its medical apparatus, particularly on the island of Lampedusa. Welcome, Dr. Alunni.
Thank you very much. Thank you very much for this invitation, beautiful invitation, and it's a privilege for me to discuss my work with you. So these days it is very difficult to really focus on our work, given what is happening, especially so when our main theme is borders and sick or wounded bodies. So that of Gaza is, among many other things, also a story of borders, hospital, lack of healthcare, enforced displacement. But our duty, I believe, is, while not overestimating our service, to go ahead and try to observe, understand, and tell these situations of suffering, and most importantly, the mechanism of production or reproduction of that suffering. This is what I'm going to try to do today with you. I focus on the case of the Central Mediterranean migration route, and in particular on what is happening on the island of Lampedusa and in the sea surrounding the island. So thank you very much for this precious opportunity. I had some simple slide to show. Okay, here we are. So as you know, or as you can imagine, and I say this because among you are some of the scholars who have most inspired me in this direction, the idea of clinical border can take many forms. In my attempt at this analysis today, I would like to focus in particular on three of these forms. The first is the articulation between medical apparatus at the border and the embodiment of the border itself. The second is the visibility of the border through clinical visibility expressed in its space. And the third is what I call here clinical detectability. So Lampedusa is an island of not even square miles in size. It's very small. So although Lampedusa is Italian territory officially, the island is closer to Africa than to Italy. So about 70 miles from Tunisia, 90 miles from Malta, and 130 from Sicily, so from Europe. There are about 6,000 permanent inhabitants, but during the tourist season, their numbers can increase as much as tenfold. Most of those tourists crowd mainly on Lampedusa's most beautiful beach, the so-called Spiaggia dei Conigli, the beach of rabbits, which means right in front of the exact site where on the night of October 3, 2013, 368 people drowned in a single shipwreck. And this is only one of the countless shipwrecks that occurred around the island, tragic episodes to which we must add those of which we have no knowledge, the many invisible shipwrecks. So according to the International Organization for Migration, in the last 9-10 years, more than more than 2,000 people in movement through the Mediterranean, the central Mediterranean, died. And I refer only to the central Mediterranean, which is between Libya, Tunisia, and Sicily. So the central Mediterranean route is by far the most lethal contemporary migration route. So the Mediterranean is an immense grave, mass grave, but beside the mass grave, the Mediterranean is also, let's say, a hospital. I mean that it is also a space where the control, management, and rescue or abandonment of people is implemented through the political, scientific, and moral relationship with their body and its sign, its symptoms, and its visible and invisible marks. In my attempt to grasp the body dimension of the Mediterranean border, my main effort is the articulation between two fundamental dimensions. Two dimensions that are sometimes complementary and sometimes somewhat in opposition. The first dimension is the apparatus of healthcare in the space of the border. Its very mechanism. I mean the medical apparatus at the border as a political and technological tool for governing migration. The second dimension is instead the body experience of the border and its forms of embodiment, and through which I refer to the experience of the border through the body of who is trying to reach it, cross it, and survive it. So to sum up, the relationship between bodies and borders is traversed by a specific tension between two extremes. So the medical mechanism that controls, regulates, and treats the bodies entering the space of the border, and on the other side, the experience of the border that migrants make through their own bodies. Of course, this is just a schematization which is useful only or mostly for analytical purposes, as everyday reality, as you can imagine, always complicates this divide. But at the same time, it seems to me that the tension between these two dimensions deeply structures some of the phenomena we can observe in the contemporary border regime, and of the ways in which bodies shape and at the same time are shaped by borders, and in particular, of course, non-white bodies. So the crucial question is, in the tension between protecting borders and protecting people at borders, what is the place of these bodies? So I'll present now a very short description of the three main stages of the border and not of its clinical dimension. So the sea, the port or the pier, and the island. These are the three parts of, let's say, the three big chapters of the book I'm finalizing about this work. So the Mediterranean border already begins at sea. I'm not referring to the divisions you can see here in this map, divisions such as territorial waters, because the maritime border goes beyond those divisions. And this includes changing and conflicting zones of responsibility for rescue at sea. Moreover, regulation and division of the sea are often challenged by non-governmental rescue entities, NGOs. So this situation has a fundamental reflection in the medical practices offered or not offered by these rescue units. To take a look at what it means, we might divide such naval rescue units into governmental and non-governmental. That is, on the one hand, the Coast Guard, as you can see here, and on the other end, the NGOs such as Sea-Watch, Doctors Without Borders, and others. But the separation between government-run and NGOs units is one that really reveals its limitation when, for example, we observe that the medical aid on Coast Guard vessels is entrusted to a private organization which is present on all government naval vessels with a doctor and a nurse. So they operate in, at times, extremely critical and hectic circumstances with many people on board and very limited technical resources, often in darkness, in the darkness of the night, or with adverse meteorological or sea conditions. The people they rescue have been in situation of extreme precarity and carry inadequate boats at sea for many hours and days and in high stress conditions, and sometimes already in situation of shipwreck, like here in this picture. Of course, there are certain aspects of their approach and training, the medical training, that are common to any type of rescue operation. For example, triage strategies such as the so-called START that you can see here, an acronym for simple triage and rapid treatment. But there are other aspects that are instead specific to the context I'm talking about. So in situation of rescue with many dozens of people on board, doctors have to choose whom to treat and whom not to treat, whom to save and whom not to save. This is obviously something that should not surprise us all that much. It is, after all, an approach ordinary in emergency situations, in all kind of emergency situations. Instead, what is more interesting is to see this, to frame this in the hierarchy of rescue and control of the sea and its borders. Doctors have, for example, have told me repeatedly, I quote, "On board, the doctor is the most important person after the captain," end of quote. This means concretely that the clinical assessment of the most urgent health condition has the power to change the course of a control and rescue mission by state units. For example, when a migrant's health condition requires immediate return to shore so that he can or she can be treated urgently on the island. The Coast Guard tend to usually to minimize the number of times they dock and depart for their rescue missions, and dock and depart and again and again. Instead, doctors generally prioritize medical emergency on board over other rescues. It means, in the reality of everyday operations, it means that if there is a person on board the patrol boat who needs urgent medical assistance ashore, and at the same time, not far away from there is another boat to be rescued, they are asked to prioritize the person to be assisted ashore and then to return to port, abandoning in some way the other boat in distress. And this is all done on the basis of a negotiation of the authority of the military personnel and the doctors on board, so the medical authority, but also between the military and the orders coming from the Maritime Control Center, which is directly linked to the central government. So it is very directly political. It is a sort of triangulation of power and decision-making that goes, first of all, through the importance given or denied to the signals of the bodies in distress. This, too, if you want, would basically be another situation of decision-making and triage, which are basic and ordinary parts of rescue, every rescue. However, the point is that most of the time, returning to port means not proceeding to other rescues. So what happens is that the clinical assessment and the negotiation between a doctor and the captain turn into a sort of clinical assessment of the value of these lives. Also, one of the cruelest way in which the Mediterranean crossing imprints itself on the bodies of migrants is the very large numbers of burns, often severe burns that they suffer. These burns are caused by a mixture between the fuel used for the old and precarious engines of these boats and the salty water of the sea. So the fuel leaks out from the old engine and settles into the concave part of the boat, and there it mixes with the seawater. It is a chemical mix that burns the skin, and it does so after giving at first a feeling of heat on the skin, which makes the person at first not worry about it. Also because it is often very cold in this situation, and so the heat in some way is pleasant, even pleasant at the beginning. A doctor who told me about this disease told me, I quote, "I call it migrant's boat disease," end of quote. Also, I noticed that these burns were mostly affecting women and children. And the reason is that women and children are often placed in the center of the boats with the idea of protecting them, when in fact the center of the boat is precisely the most exposed area to those kinds of burns, because that's where the water and fuel settle and mix. So it means that a certain idea of vulnerability and protection corresponds instead to a specific and literal, very literal form of embodiment of that journey. But that embodiment also concerns existing social hierarchies. For example, when these burns affect poorer migrants able to afford all the place in the boat's hold, which is the lowest part, and thus they're exposed to the greatest risk of getting injured or dying during the trip. Things, so here you can see one of these rescue operation, the condition where physicians sometimes have to operate. Things are quite different for certain aspects with NGO rescue ships. As you may know, in the past few years and still today, there is an ongoing lethal struggle between Mediterranean states, especially the European Mediterranean states, and search and rescue NGOs. Italy and Malta routinely ignore or respond slowly to distress calls, leaving people in dangerous situations to drift at sea for days. And Italy, the Italian government, seizes NGO ships for varying periods of time with different pretexts. In addition to all that, the EU-funded, EU-trained, and EU-equipped so-called Libyan Coast Guard also intercept thousands and thousands of people at sea, returning them to detention centers in Libya, where a very large portion of migrants, mostly from sub-Saharan countries, Middle East, and from other countries, converge to reach the central Mediterranean route. And in these centers, abuse and extortion and torture are reported as completely and tragically ordinary. So you can see here, that's the cover of a very famous magazine in Italian. It says "The New Pirates," without any romantic side about the pirates. So not only there is the EU's withdrawal from search and rescue activities in the central Mediterranean, but also an increasing criminalization of the NGOs and the civil fleets that have attempted to fill the gap, including medical NGOs such as Doctors Without Borders and others. So the techniques of criminalization are several, but now I focus on the repeated denial of the permission to dock at the port for NGO ships after the rescue operation. So the ban on disembarkation to NGO ships after they have carried out a rescue operation means creating long standoffs at sea. This means creating a situation where those who need treatment cannot disembark and be treated in a hospital on land, or situation where medical problems emerge precisely because of that long wait. let alone mental issue, which is a huge field that goes below the specific notion of urgency at the border and is almost completely missing from the border healthcare apparatus. So what happens is that NGOs, medical staff, most of times choose to let the claim of the right to healthcare prevail, which means that the right to get those who need medical care out of the ship prevail. And this often results in a progressive shift in which we can observe the attribution of vulnerability start with a clinical assessment that progressively includes more and more people, eventually leading to the disembarkation of all migrants on board after medical inspections. So, as you know, the right to rescue and disembarkation is described in all the most important international regulations and treaties, and more in general in maritime law. There should be no need to resort to the medical argument. Yet, in almost all my conversation with medical personnel of these NGOs, the doctors and nurses express an assessment that is not only strategic, but based on the belief that the priority drive for disembarkation is medical, must be medical. On the one hand, there is, for example, the director of the Maritime Health Authority who told me explicitly, I quote, "I'm a doctor of the state, I'm paid by the state, I obey the state," end of quote. On the other hand, there is the doctor of an NGO who claims the right to disembark for all the migrants on board because, I quote, "After all migrants are vulnerable," end of quote. So beyond any, as you can imagine, any problematic issue in terms of medical deontology, what seems to me to emerge from these positions are different forms of politicization of the body, and in particular, of the suffering body. And above all, this is a politicization that is in some ways paradoxical. It is paradoxical, because it goes through the invisibilization of the non-sick body. And it is paradoxical because it makes the right to healthcare prevail over the right to rescue at sea and the right to disembark in the nearest place of safety, as the law requires. It is something that goes beyond depoliticization. If we look more closely, I think all this means moving even closer and perhaps too dangerously to a conception of rescue in terms of biological characteristics, but not politically qualified lives. In any case, what happens next is precisely the moment of disembarkation, the arrival at the so-called POS, the place of safety, the port, the pier. So this is Doctors Without Borders physicians on board. And this is the pier of Lampedusa for migrants, reserved to migrants. So at one of the main beaches on the small island, you can see tourists relaxing, sunbathing and swimming in those crystal clear waters. But just in front of them, on the other side of the small bay, there is the military pier, and above that pier, groups of people who have just gotten off a Coast Guard rescue ship or an NGO ship, or their own very precarious boat with which they have just crossed the Mediterranean. Once disembarked, migrants form a line to be quickly examined one by one. This medical inspection consists of a very quick check for possible symptoms of contagious diseases or major symptoms, possibly requiring urgent care at the small local hospital. So the most recurring issues are skin diseases, respiratory problems, orthopedical issues, chronic disease, but also very serious burns, as I told you, injuries or problems linked to, for example, to pregnancy, which is only one of the many ways health issues linked to this kind of migration emerge as an extremely and violently gendered experience. So in general, there are ordinary inspections and more urgent inspections like this. For example, when sick or wounded people are brought to the local hospital by ambulance. So I was allowed to enter this military part of the port on a regular basis because I was embedded in the hospital staff who was always present at disembarkation. And this allowed me to witness, or rather to participate, problematically enough, not only to large numbers of arrivals, but also to thousands of these quick medical inspections. So of the many possible elements, the only one I briefly discussed today with you is the variation in the parameters by which the physical problems presented by these migrants are evaluated. I'm referring, for example, to the fact that certain symptoms were taken into account today, but ignored tomorrow, or that certain medical situations were considered worthy of the transferal at the hospital today and not tomorrow, or that certain categories of migrants were considered reliable today, but not tomorrow, or finally, that certain narratives of pain were considered true today, but not tomorrow, and so on. So what I could observe and discuss with all the actors were the constant shifts in what I would call the line of clinical visibility of the border. It was a line that moved sometimes very clearly, sometimes in a very subtle way, depending on parameters directly related not to health management, but to the political management, the political circumstances of the border regime. And it is never simply a matter of decision-making, triage, or a simple, let's say, resource versus diagnosis calculation. It is instead a clinical gaze that changes in a way that is both unconscious and directly shaped by explicitly political rationales or political agendas. So this shifting clinical gaze becomes a problematic discipline of migrant bodies when xenophobic politics and moral and political instances of individual doctors converge in racial patterns of medical exclusion. I give you just a very little example, very, very small example. Sometimes I observe very often something that I observe very often. That is the inability or the unwillingness to detect or identify the small dermatological signs of infectious disease on different skin colors, with all the consequences you can imagine in terms of triage, treatment, and limitation of the spread of infectious diseases in the detention centers. So with such diagnosis at the intersection of race and disease, we move from a biosecurity mechanism at the border to a medicalized prejudice. So that peer emerges as a space where the governmental process of registration, inspection, and description of bodies at the border become rather explicit and ethnographically observable. But what kind of inscription are we talking about? So we know that this kind of medical inspection have a long history, a long genealogy. Think, for example, to Ellis Island. This is Lampedusa, so you can see the similarities. But such genealogy is sometimes often misleading, because despite its many unacceptable and often tragic characteristics, these were mechanisms for the production of legality in some way. In the case that I am presenting, however, there is a mechanism for the production of illegality. In other words, it is an inscription of bodies that happens in a space of management or production of the so-called illegal migration, and also the site where that illegality gets inscribed on bodies. It is more precisely a threshold where bodies come to be constituted as an object of power, of medical knowledge, and the site of political calculation and intervention such as the intervention we are observing at the lethal European contemporary borders. So all this becomes even more explicit and definitive once migrants leave the threshold of the port, the pier, which is the local hospital and the hotspot of Lampedusa, is its detention center. So one of the immediate effects of triage at the port is the division between those who are sent to the detention center or hotspot and those, very, very few, who are sent to the hospital if they present urgent medical issues. I'm not going into the details of these two contexts, but I would like just briefly discuss some of their common characteristics. So as you can see here in this picture, the detention center is located in the middle of the island, hidden at the bottom of a small rocky valley. And the hospital is not even a real hospital. Its technical equipment and its personnel are very limited, and the most urgent cases are transferred with an helicopter to, let's say, real hospitals elsewhere, especially in Sicily. So both contexts offer extremely rough medical service. So during my long hours and days and nights at that hospital, there were constantly times when the most controversial moral and clinical assessments were quite explicit. The fundamental traits of the healthcare apparatus at the border that emerged over there was the structural and racializing role of distrust and suspicion. Such feelings and approaches emerge in particular when medical staff ascribe to arriving migrants the tendency to stage their own health problems or to create them on purpose for a supposed strategic awareness of possible advantages. What seems relevant to me here is to try to understand the tension between something we might call moral mistrust on the one hand and political suspicion on the other. All of this has some extremely relevant consequences on multiple levels. For example, the role of medical records and diagnosis in individual migration stories, or more precisely, the role of the suffering body in the process of asylum requests. Neither in the local hospital nor at the migrants do not receive any formal medical documentation concerning the health issues they present when they enter the space of the border. This means that subsequently, those migrants will be not able to certify certify those issues for the potential application for asylum. This situation of rough and racialized healthcare plays a central role in the vagueness, uncertainty, and arbitrariness of the margins of the state, leaving the island without any certified diagnosis means leaving the island without the recognition of possibly crucial elements for the following step in the migratory process. This is not a simple acknowledgement of some sort of deficiency of the border apparatus. It means instead observing that the most effective and critical mechanism of production of uncertainty and arbitrariness is precisely the medical and bodily side of the border regime. So more in general, all this creates a fundamental shift. So clinical triage becomes migratory triage. In other words, the clinical sphere of its medical apparatus, the border apparatus, overlaps with the management of the border through an extremely repressive discipline of subjectivities that in that space resort to their last possibility for expression, which is the narration of symptoms and pain and the different forms of embodiment of the border. We conclude very briefly with some quick remarks. More generally, as you can see, I'm trying to grasp what happens to those who enter the space of the border in terms of ambiguous and uncertain threshold of clinical detectability, a space in which, as we have seen, the clinical gaze at the border is no less important than a clinical gaze on the border, or a space where it becomes possible to detect clinical signs and symptoms that hover between being identifiable or not, or we might say clinically visible and enunciable or not. So in this light, the multiple entanglements between the body experience of the border and its medical apparatus are what really constitutes the deep essence of the border. It might sound like a sort of bodily determinism, but every single diagnosis, every single misdiagnosis, every medical interaction, or in short, every event related to the migrants' bodies expressed an assessment of the value of their lives and the real meaning of protection. And it happens in a way which is specific to the border. So this is why, to conclude, the definition of the border that I would like to suggest is that of a space determined and defined by this differential evaluation of the value of lives, a space whose very existence is based precisely on those differential and clinical evaluations. And I consider this definition quite an operational and a very concrete one, because in the action of activists, NGOs, civic committees, physicians, and even some scholars, I could see their ability to intervene in those evaluations of the value of life and the possibility of subverting or limiting, at least limiting, the violence of those evaluations. And all this showed their precious and concrete ability and potentiality to transform that deep essence of the border. Thank you very much.
Thank you ever so much, Lorenzo. That was a powerful, insightful, and horrifying exposition, really taking us into the midst of really some extremely difficult scenes, and also with a very acute ethnographic and analytic eye. Thank you so much. Thank you very much for your talk. I would like to remind people that they could use the chat function of the Zoom here to be able to send questions, which I'll be glad to be able to pose for you. Now, you actually pretty much anticipated one that I was going to ask. Maybe you could say a few minutes more, a bit more about it. Your description of the medical inspections on Lampedusa really reminded me precisely of the historical literature of Ellis Island, of the way in which, that is, steerage class, poor immigrants were required to walk up a set of stairs carrying all of their suitcases and belongings, precisely to be able to see if the bodies would be suitable for working. And so that where the first experience of the United States was precisely medical examination. I also think about the news coming across the United States today about revelations about the death of Melvin Ariel Calero Mendoza, who had a serious blood clot in his foot and was basically allowed to die in U.S. Immigration detention. So thinking about this interesting mix between, on the one hand, the medical surveillance of the body and also neglect. So you really, I think, began to sort of tell us a bit more about it. So thinking about the historical dimensions of this, how do you see, I think that was a fascinating insight to think about the medical production of illegality rather than legality through migration. I wonder if you could tell us a bit more about some of the broader historical parameters that you see here.
Sure. Thank you very much for this question. When I describe the comparison between historical situations such as, for example, Ellis Island and the current situation in Lampedusa, and when I say that it is precisely a sort of machine of production of illegality, I mean it in a very concrete way, because if you think of the system, what happens on the island after arriving in Lampedusa, so you have migrants arriving in Lampedusa, migrants that almost all the times are declared illegal in the sense that they are not entitled to asylum, to protection. Then from Lampedusa, they are transferred through cruises or military ships to the mainland, to Sicily or elsewhere in Italy. Then they enter a process of detention and expulsion. But there is not a system through which these people are taken from the state and brought back to their countries of origin, but they are in some way abandoned in the country, in Italy, with a document telling them that they must abandon the territory, the national territory, within, it depends, 2 weeks, etc. It depends. What happens almost always is that these people remain in the territory and goes to being part of, for example, the agricultural undocumented workers, for example, or they continue their trip trying to cross, for example, the Alps and going to France and then to Calais and eventually, hopefully, to Britain or somewhere else. So when I say that this illegality is described in the bodies, I mean it in a very specific and concrete way. And this is why all this problem, all this machine of production of illegality intersect with the other form of arbitrariness of the border, which is never giving medical documentation certifying the issues diagnosed at the border. So the two things go together, and that illegality is based on a non-diagnosis and non-healthcare, the inexistence of healthcare documentation. So I mean it in a very, unfortunately, in a very practical way, machine of production of illegality.
Thank you so much for that. One note here, actually, the best place to put your questions would be in the Q&A section. I would also like to mention, since there's another person here on the camera, this is Dr. Claudio Montini-Briggs, who's an affiliate of the Berkeley Center for Social Medicine. So we have a couple of questions here. One asks, who's paying for the medical treatment of these migrants?
So if the question thank you for the question. So if the question refers to the medical treatment on the island, it's a public hospital, so an outpatient clinic, and the state paid for this medical treatment simply because in the Italian law, in the Italian constitution, so medical treatments are free and universal for everybody. So I'm not saying that I'm quite proud of this, because I'm not, because it's under attack and it's changing. But nobody, the state pays for this. Nobody, migrants are not required to pay for this, even if the current government, right-wing government, is promoting a law asking foreigners present on the territory to pay 2,000 euros per year to get the privilege to have public healthcare. But I'm not sure it will pass. So the national health system is universal and free, and the same is for people getting treatment at the border.
Well,
after that, there are many considerations about the quality for the treatment and all what I said but on a theoretical, bureaucratic level, it's free.
Well, I'm pleased to say that at least so far, Italy remains in those terms a civilized country, unlike the one in which I happen to be sitting at this moment. Another question. Did you experience in your research the criminalization of medicine, doctors, health workers, and organizations, the way we saw the criminalization of rescue missions? And there's a follow-up question in there. What role can the health NGOs play within the international and European legislation?
Thank you very much for this question. As for the first part of the question, I have to say that unfortunately, there is a sort of game of criminalization in terms of, NGOs are putting in front the need of medical, treatment, as I told you during my talk, the healthcare urgent needs of these people. This means that the first effect of criminalization is precisely the criminalization of doctors, in the sense that what is doubt is precisely the medical authority. So the accusations that happen all the time right now is that medical teams of NGOs are ideologically oriented, etc. So we cannot trust the medical authority, the medical assessment. On the other side, we know that state, in particular the current government, asked something very precise to state doctors doing inspections on board. So there's a political struggle which focuses particularly on a struggle on the concept of medical authority, which is something very, let's say, very interesting also from a deontological point of view in terms of medicine. But the result is that the struggles, as I said during my talk, is always on the healthcare level, forgetting, and this makes us forget that we shouldn't need to go to that level. So there are treaties, etc. As for the second part of the question, the health NGOs, which is that are NGOs in general, which is usually health NGOs operating on board of ships, collaborate. The different entities collaborate. So you have, for example, Sea-Watch with onboard doctors belonging to another organization and association. Their main role in these last few years, it's a role of, as I can say, so as I told you, areas of search and rescue are very conflicting area. I mean, you have states like Italy and Malta telling, no, you must rescue that ships. No, you must, and nobody rescued these ships. And NGOs have the incredible power to, in some way, put all this in a very productive disorder, which is a challenging disorder, which is challenging the international diplomatic relationship between countries that are refusing to rescue these people. So I think my view is that we have to be grateful to NGOs for many reasons. On this level, the main reason is that they have this power of create a sort of mess and challenge this very ill and violent order. I hope this answer to the question.
Well, I'm pleased to say that your talk inspired quite a number of questions. I'll jump to one which suggests, I was interested in the different kinds of triage and categorization of people, injury, suffering, and the like, that take place in the sea versus on the pier versus on land, say in detention centers and hospitals. How the clinical gaze changes within each of these spaces and then changes across these different spaces. What do you see in terms of the relationship between these different sites and scales? And I must admit, I would want to add one thing that's interesting in terms of thinking about triage and categorization, what role that race, the sort of racialization of migrants might play in that process.
Yes, thank you very much. It's a huge question. So I think that the most important thing to say about the difference between the clinical gaze on the boat and on the pier is double. The first thing is the speed of this kind of clinical assessment. So as you have seen in the pictures, doctors on board of these ships are forced to operate in a very complicated situation with usually many people on board and extremely limited technical equipment. At the same time, what happens on the pier is that the medical inspections and the treatment that happens on the pier are carried on by someone else. So on board, there are private organizations and non-governmental organizations offering this kind of healthcare and triage and treatment. Whereas when they arrive at the pier, the medical authority and the medical control of the situation is transferred to the local public health authorities. So as you can imagine, there is a huge difference in terms not only of medical approach, so clinical, how their clinical gaze is shaped, what are the elements at the base of that clinical gaze, but also the relationship with political powers in terms of, for example, the number of people transferred to the hospital today and the number of people transferred to the hospital tomorrow. And sometimes, very often, this number changes, not because the boat arrived today, the people on board is healthier than the people arrived tomorrow, but because the changing borders from the local and the national head authority and the political authority. So this is why during my talk I said that this what I called a line of clinical visibility changes due to political agendas. I said this on a very concrete, in very concrete terms, because I personally saw that a phone call from the offices of the Ministry of Health in Rome to the local doctor in Lampedusa directly changed the clinical gaze of that person. Not only that, for example, a symptom that he sees or she sees today, okay, he or she knows that she can take that person to the hospital, and tomorrow no, because they told me to limit the number of people to be brought to the hospital. But also because their clinical gaze changed in a very embodied way, also for the doctors, not only the migrants. So what is interesting to my understanding is also the ways through which these political agendas linked to clinical visibility were directly, sometimes in a certain way, unconsciously embodied by these physicians. So I know it's a huge theme, and I can't, but I would be happy to answer more in detail. Yeah, maybe I can write my email address if someone is interested to get in touch. Sorry. Yes, here it is.
That was absolutely fascinating. Reminds me of times when a call from the Minister of Health to local health authorities would change the case definition of an infectious disease precisely to lower the number of cases of cholera or whatever you might happen to have in the middle of an epidemic. We have a very interesting question, and I'm happy to be able to identify the questioner as Deborah Lustig, who's the Associate Director of the Berkeley Center for Social Medicine, as a means of also being able to thank her for making both the center and this event possible, and also Max van der Varker, who's the Chief Administrative Officer. And her question, which she could also ask if she likes, but I can read it as well. She would like to hear more about any movement or pressure to reframe the issue from one of humanitarian assistance for medical treatment to one of rights for migrants.
So reframe the issue in terms of the role of the humanitarian organization in this situation, or
You're welcome to jump in, Deborah.
Yeah, I mean, you made a very clear and compelling case that it's being framed as an issue of medical treatment for people who need it, and that the fundamental rights that some of us might identify as being essential are not the focus. So I'm wondering if, you know, what kind of pressure is there, social movements, activism to, you know, change this dynamic that you've identified in your talk?
Yes, absolutely. This is why I took the opportunity to express my gratitude to NGOs, because as I said in the kind of definition of border I suggested at the end of my talk, I saw that this challenging activity of NGOs and also local organizations in Lampedusa can really put this situation under light, make this situation visible, because the most important, the most crucial thing that states, Mediterranean states, especially Italy, are doing is making all this invisible. So one of the reasons why there is this criminalization, ongoing criminalization of NGOs, is not only for the thick idea of NGOs as a pull factor of migration, which is totally, completely false, but also witnessing. So on one side, we have this kind of struggle against the witnessing. So the criminalization of witnessing, even before criminalization of rescue. On the other side, we have the paradoxical and more problematic side of this kind of humanitarian approach by NGOs who decided strategically and with good reason, I think, to focus on the medical side of their activity. Because on one hand, I think that in strategic terms, it's something that works. That at the end, all these people disembark, and at the end, these medical inspections and medical assistance, it exists, so it works. But on the other side, it's a sort of anti-political activity, which is totally paradoxical from a deeply political entities such as NGOs, and all this is played on the bodies of these people in movement, which is really troubling, and which is what make me suggest that the border is precisely the space where all this kind of illegality is inscribed as a scar on these bodies.
Very powerful. I'm going to apologize. We have a number of remaining questions. Even though we're a little bit over time, I'm going to see if we can end with one which I think is actually brilliantly captures one dimension of the situation that you're describing, but let's say opens up much more broadly to contemporary events. So the question is, what legal frameworks exist to protect doctors and health workers during times of crisis or conflict?
Well, I think that we thank you, because it's, yeah, you're right, Charles. It's brilliant, brilliant question. So thank you very much. I think we have to be careful not to fall into the trap of the idea of crisis. In the case of the Mediterranean route and in the case of Lampedusa. So Lampedusa is one of the examples where you can see as how the notion of crisis it can be some way weaponized by the state. Because, for example, when I told you that in Lampedusa there is not even an hospital, it's just a little outpatient, little clinic. I don't remember. So it's not really an official hospital. And when I say that the medical resources are extremely limited, I'm talking of a situation which is considered every day, considered as an emergency situation, but it's ongoing from at least 15 years. So I think that we should be careful in talking about crisis in these cases. In terms of legal frame, so we have this paradox. On one side, there is a state that says, okay, we offer to these people the public the resources of the public health system, healthcare system. So when they are on site, they can be treated by the local little public hospital without any additional resources. So it's just the same little local hospital for the little population, permanent population of the island. On the other side, the same state claims all the time that there is an ongoing crisis, that we must close the border, we must tighten the control at the border, etc. So there are two conflicting legal frameworks. On one side, the ordinary legal framework for healthcare provision. On the other side, the crisis, let's say the exception, the state of exception legal frame. And they are activated in a very differential way and as a tool, fundamental tool for the very problematic and ambiguous management of that border. This is why I always doubt of the idea of crisis in this situation, because okay, if we acknowledge that there is a crisis, so we should activate all the resources for this crisis, including medical resources, which are always absent.
Well, I can't thank you enough for coming to the Berkeley Center for Social Medicine, even via remote means.
Thank you so much.
A wonderful talk. I think we could talk for hours about this. I wish we had the time to be able to explore all of these questions and issues in depth. If I, again, want to thank everyone who participated, including those who are participating through the webinar. If you have any final words for us, I invite you to say them. Otherwise, we'll begin to close the event.
I would only like to really thank you for this opportunity. Really, you're among the people who most inspired my work. So thank you very much. It's a real privilege.
Well, thank you very much. Again, let's give a round of applause to Lorenzo.
Thank you.
Thank you, Lorenzo, for joining us. And also, maybe I'll mention thank you to Ariola Oni Orison, who originally put us in touch with you and suggested your work. So thank you for joining us.